Got diagnosed with type 1 diabetes a year after losing all that weight on a family trip, and it could have extreme consequences. Never seen glucose control this good in my office ever. This is actually a therapeutic diet with therapeutic medicinal properties for centuries.
You are going to have insulin resistance because of the insulin.
The amount of carbohydrates needed for brain health is zero. It has failed both the patient and the healthcare practitioner. Both of them. It has caused the relationship between them to be fragmented.
There is an urgent need for the guidelines to be changed.
This is a myth. It is something that has, I think, damaged patients.
Hi everyone, I'm Shwetha Bhatia, registered dietitian with the Indian Dietetic Association. In today's episode, we're talking about something that often gets pushed under the rug, especially in type 1 diabetes care, the role of low-carb and ketogenic diets. I have successfully implemented therapeutic carbohydrate restriction in practice to manage type 1 diabetes. In fact, I've been on the diet since 15 years and use it across clinical and sports performance cases across age groups. I am joined by Dr. Dr Koutnik, an award-winning research scientist at the forefront of diabetes and chronic disease research, integrating nutrition and metabolism to set international therapeutic guidelines. Not only has he reversed his childhood obesity, but also effectively managed type 1 diabetes for over 17 years, and that's what makes this episode special. He has more than 100 peer-reviewed publications and international presentations to his credit. We'll be breaking down myths, talking about practical barriers, especially in the Indian context, and diving into how insulin, ketones, protein, fat, and lifestyle all come together when you go low carb. This is an open and science-backed conversation. Whether you're a dietitian, a type 1 diabetic warrior, or just curious about carb restriction in chronic conditions, this one's for you. So let's get started.
Let's just begin with a little intro about yourself. I'm really keen to know about your personal journey, especially with type 1, and how you kind of got into using the ketogenic diet for managing type 1 diabetes.
Okay. My personal journey started over 17 years ago. I actually 2 decades ago, if you consider that I actually started with obesity. So I was obese as a kid, was gaining more and more weight, more and more fat tissue. Eventually was able to lose weight with obesity, but then got diagnosed with type 1 diabetes a year after losing all that weight on a family trip. And it was a pretty devastating diagnosis. You immediately realized that at every food, every meal of every day, you're now going to have to understand the food, the complex nature of how it's going to affect your metabolism. And now you're going to have to make medical decisions with a very, very powerful hormone, arguably the most powerful hormone in metabolism at every meal of every day. And it could have extreme consequences. And I remember the first time I walked out of the hospital and sat down to eat food, I was completely overwhelmed.
Yeah.
And it took me a long time to realize that this disease, while overwhelming at first, could be one of the best superpowers in understanding metabolism, and turned it out to be one of the greatest assets that I've ever had.
Great. So kudos to that. I mean, I understand the mental baggage that comes with chronic ailments, especially at such a young age. So well done with that. What prompted you to ketogenic diet to manage your condition? Because if you look at the governing bodies, there aren't any guidelines as such.
It actually started in athletics because I was always into sports. I was always into lifting to be bigger, stronger, faster, and doing what I could, both from exercise and nutrition, to accomplish that.
Right.
And I had heard of the ketogenic diet for its ability to potentially prevent the loss of muscle while losing fat. And I thought, oh, this sounds magical. I want to try this, right? This is before I got an advanced nutritional degree and understand there's a lot more nuance to that. But that was the actual start, was very much trying to just improve my own performance, improve my body composition. And at this point, I was well over, I had had type 1 diabetes for some time. And I remember switching my diet. And I went to my doctor's office about 3 months later and found, he's actually the American Diabetes Association president that year. And he sat down with me and he said, Andrew, what are you doing? And I said, well, what do you mean? He said, well, I've never seen glucose control this good in my office ever. And it was like, oh, I'm doing something super special. And at this point, we didn't have continuous glucose monitors. We didn't have all these advanced tests to see glucose control at the time. So I was only seeing little snapshots within each day with a blood glucose meter. And so when I walked in and I had a HbA1c at 5.5%, which for your audience, if they're using different metrics, is in the non-diabetic range.
Right.
Okay. So not even pre-diabetes, not even type 2 diabetes, but in the non-diabetic range. I thought I must be doing something special here. I certainly felt better. I was performing better in the gym. I was often not having these fluctuations up and down and how I was feeling, both cognitively and physically. But I didn't realize that it was translating to a biomarker that had huge implications for health, huge implications for long-term outcomes with diabetes, but also implications for how someone may perform and reach peak performance. So it was an eye-opening experience when I first did it. But actually, I started for athletic reasons and body composition reasons, but it soon became a health journey for why I continued it.
Right. I'll just tell you a little bit about myself and how I decided to use the diet. So as you already know, I'm a registered dietitian, and none of this was taught to us in college. But I started using the diet about 5 or 6 years ago. And basically I used it for a case of epilepsy, as we were taught that, it fits in right there, and I got great results on it. But then when I started reading the whole physiology and how the body, the biochemistry, how it works, I decided that I should actually try this out for other conditions as well. And just to give you a little idea, I've also dabbled with bodybuilding a little bit. I'm not a competitive athlete, but I've been training very intensely, and I used the diet for improving my body composition when I stepped on stage. And I also used it for a lot of clinical conditions with fabulous results, initially only for clinical conditions. But since the last 4 or 5 years, I've been also using it for sports performance. I also have a type 1 diabetic athlete who's a professional cricketer, and he's got some fabulous results on the diet. So I literally now use it for everything under the sun, because as you know, India is the world's diabetes capital. And I'd also like to add that I've reversed a couple of cases of fatty liver with the diet. So which has been confirmed by a sonography and a fibroscan. So grade 3 to grade 2, grade 2 to grade 1. So it's really amazing, the diet. The only challenges that I face here is that, everybody thinks that carbohydrates are an essential nutrient. And that's one of the reasons why people are really scared to switch and use protein and fat, and rather use body fat as the alternative or primary source of fuel. And the other aspects are because India is a very carb-heavy country per se. That's the predominant nutrient on our plate. It's very difficult to switch to a diet like this until and unless your environment also kind of is conducive for you to follow the diet. So accessibility, budget, these are a few challenges that we face here. But I think mainly the main challenge is the idea that it can cause heart disease, that it will damage your kidneys, and the carbohydrates are essential. So do you have something to say about the effects of the ketogenic diet in the long term?
Yeah. So it's really interesting that you describe its use in epilepsy earlier, because before it was ever even used in epilepsy, it was standard of care for type 1 and type 2 diabetes and obesity, going all the way back to 1797 by a physician named John Rollo. There is a report called in Diabetes mellitus, 2 cases of diabetes mellitus, where he described over 2 centuries ago its use. So a meat-based diet, so essentially a low carbohydrate meat-based diet, probably very analogous to what we now consider ketogenic and or carnivore-based diet. Right. For the treatment of diabetes, and it worked remarkably. And we've known for years, even after that report, that it became standard of care for its use in all forms of diabetes at this point. Now, you also mentioned this idea of the concern around its potential implications in heart disease. So, one thing to appreciate is that oftentimes people look at all this emergent exciting data of its use in the ketogenic diet and think, wow, this is remarkable. It can address neurodegenerative disorders, neurological disorders. It can prevent and reverse obesity, type 2 diabetes, manage chronic irreversible diseases like type 1 diabetes, which I live with. It seems too good to be true. But what's really remarkable is that you actually can look back historically and see that they were using it for many of these conditions for centuries. So the idea that it's this emergent diet and we're just trying to figure it out and is it going to cause this overwhelming harm is to look back at this is actually a therapeutic, a diet with therapeutic medicinal properties for centuries. Right. It's not new, for centuries. Now, its concern around cardiovascular disease largely has arisen because we now have the ability to measure blood lipids. And since the emergence of measurement of blood lipids, we've seen this association with particular blood lipids like LDL cholesterol and the rise of, or the association of elevated levels of LDL with elevated levels of cardiovascular disease. Now, when we talk about diseases that have some of the highest risks for cardiovascular disease and mortality, we're talking about diabetes. Diabetes has tenfold higher risk for cardiovascular disease. Right. But when you actually look at the risk factors within diabetes, so the biomarkers you can focus on, both as a patient, as a healthcare professional, what should we change? What should we improve? The number one risk factor for both type 1 and type 2 diabetes is something called HbA1c. It's a measure of long-term glycemic control. So glycemic control is the number one risk factor. Below that, particularly if you look at studies that have over 30 years randomized controlled trials and over thousands of patients, and particularly in things like type 1 diabetes, we actually see that if you look at modifiable risk factors, so things you can actually change, you can't change your age, you can't change how long you've had this disease for, but what you can change is glycemic control. Below that, blood pressure. Below that, triglycerides. Then you have things like resting heart rate. And at the very bottom of that list of the 10 biomarkers they looked at was LDL cholesterol. So this concern around LDL cholesterol isn't invalid. It is a risk factor, but it's a risk factor with infinitely less risk when you actually model the association between what in health actually predicts cardiovascular outcomes, particularly in diseases with extremely high risk for cardiovascular disease. So when we think about the most important risk factors to improve, we should be focused on glycemic control first. Right. Then things like blood pressure, triglycerides, which, by the way, low carbohydrate ketogenic diets are very good at improving for people. Then at the very bottom of the list, after you focus on those biomarkers and prioritize what matters most in cardiovascular disease, then you can consider things like LDL, because again, it's all about what matters most. What's the risk factor hierarchy? And LDL is very low on the list. It doesn't mean it doesn't matter. It just matters a lot less compared to these other metrics.
I'd also like to add, as we're on the topic of LDL, that we know about this concept of the lean mass hyper-responders on the diet, right? And we know that these people typically have lower insulin levels. I'm talking about people with obesity, not with diabetes per se. And they also have lower triglyceride. And the LDL is bumped up a little bit, but the ApoB is normal. So all good things happening there. I don't think there's any chance of your heart getting hit by that profile. So when we do the lipid profile, when we repeat that after a month or so of the client being on the diet, we realize that when we check the lipid ratios, when we check the changes in the lipoproteins, it's a favorable outcome or a more favorable profile than when we started. Definitely the triglycerides drop, so that is a good sign. There's a subset of people who don't respond well to saturated fat. That's when we kind of modify the kind of fat in the diet, and therefore the whole approach is very individualized.
And I want to, this is a very important topic because you bring up the lean mass hyper-responders, which got a lot of interest. It has continued to for quite a number of years. And there's this recent publication where it kind of caused a firestorm about the idea of whether there's an increased risk of heart disease in this population or not. Keep in mind that when someone goes on a ketogenic diet, most people are not going to see elevations in LDL to the point where they are what is considered a lean mass hyper-responder, which is over 190, around 200 milligrams per deciliter in LDL cholesterol elevation. That is actually very rare and uncommon. So when someone does this diet, they shouldn't expect, oh, I am a lean mass hyper-responder. It's actually very unlikely you are. Most people are going to probably see an elevation in LDL if they increase their saturated fat intake. And as a result, they may elevate a little bit, like mine doubled. Mine went from around 60s to 120 milligrams per deciliter, whereas a lean mass hyper-responder would see north of 200 milligrams per deciliter, some north of 600. This is a completely different scenario than the average person who's going on a ketogenic diet. But that said, anytime we're looking at cardiovascular disease or any risk factor, we're always thinking about the composite risk. So because cardiovascular disease isn't one thing. It isn't LDL goes up, you get cardiovascular disease. It is, what is the metabolic composition, the dynamic interaction between those biomarkers? And then how does that relate to your overall risk? And so it isn't one thing. It's a cluster of things that combine together. But yes, if someone were to have remarkable glycemic control, lower insulin levels, and, the related improvements of other things like blood pressure, triglycerides, which we know are all associated in primary risk factors and diseases like diabetes, then this would be considered a favorable improvement. But beyond that, we've also looked at this over a 10-year period. So we've actually looked to see what is the risk of someone getting early signs of cardiovascular disease before you'd even see a calcium score. So a lot of studies look at calcium scores because they are the most important measurement of if you have an elevation that it would predict future risk. But even before that happens, before you start laying plaque and seeing calcium on a scan, you actually see changes in the vascular wall, how it functions, how compliant it is, how the heart functions. We see this much earlier on. We see changes in children much earlier on that predict future atherosclerotic progression. And we've actually assessed the ketogenic diet from over a 10-year period to see its impact on cardiovascular health.
Okay. And there hasn't been no association with heart disease over that period.
So when we looked at that, we looked at a high risk disease. So type 1 diabetes. Type 1 diabetes has tenfold the risk for cardiovascular disease. And we did a ketogenic diet where we had data that was over a 10-year period where body composition, activity level, calories were all controlled, including the fact that this particular case, there was no change in medication. So about as controlled of a longitudinal assessment as you can possibly see. And what we observed in this case is that when looking at signs in a case where type 1 diabetes had been present for essentially 16 years. So we see early signs of atherosclerotic changes or changes in the vascular wall and heart that would lead to future risk for cardiovascular disease within 4 years within children. Okay. So we see these signs very, very early. In this particular case, we were 16 years into the disease, and 10 of those years was on a ketogenic diet. And we saw no signs of early indications of atherosclerotic progression. We saw, in fact, in many cases, the measurements of vascular function and heart function were better than the age and sex matched individuals who don't even have diabetes, who are completely healthy matched controls. So this really helped give us insight that there's a possibility of the profound therapeutic potential of these diets, even in high risk diseases where cardiovascular disease is tenfold higher on average.
Right. I've been on the diet myself for the last 15 years and I'm never going to look back. So like my reports are really clean and nice. And my LDL stands at around 120 or 130 at the max. And I consume a fair amount of saturated fat. Right. So yeah, coming back to type 1, this concept of double diabetes that's hit us now. There's a requirement for us to keep that insulin dosing down as much as we can to the bare minimum. Earlier on, the concept, let the child eat what the child wants to eat because we have growth to be, factored for, and then increase the amount of insulin. And I had to counsel parents and tell them that that's not a healthy way to take this disease forward in terms of management because you are going to have insulin resistance because of the insulin now, and that exactly is what we're talking about now is double diabetes. So do you want to say something about that and, why the ketogenic diet helps in that context?
Yes, let's first address the concern that pediatricians or parents often have revolving this diet and young populations. The concern is that, if you do a ketogenic diet and you lower insulin load, won't that potentially impair growth or have some other type of associated risk? Well, it's, number one, children with type 1 diabetes already have impaired growth, which is linked and associated with dysglycemia or poor glycemic control. Okay. And so we also know that elevated and variable glucose levels disrupt growth hormones. So
Right.
the one specifically associated with vertical growth, which is what we're concerned about. So IGF and IGF
Right.
binding proteins interaction. So if we know that the one thing that changes primarily when you have type 1 diabetes is that you have poor and variable glucose control, and that is linked to growth hormones related to growth. If we can control that as a primary risk factor, that seems incredibly important. But also keep in mind that there is no substantiated evidence in the context of type 1 diabetes that it does impair growth. In fact, the largest observational analysis of over 300 patients, of 42% of which were children, so no growth impairment compared to others
Right.
when doing this diet. So the idea that this diet does impair growth is not substantiated by evidence at this stage. And keep in mind that the concern around growth is marginal in comparison to the real risk of what poor and variable glucose levels do in children. We know that children have the worst glycemic control on average. They have the poorest management. And we also know that they are seeing changes in their brain function, in their
So,
brain neurological growth, and their vascular wall related to poor glucose control. So
right.
the idea that we should give up glycemic control that this diet may provide in lieu of something that is hypothetical and not substantiated by any evidence, in fact, the opposite, evidence shows that it's not happening,
Right.
is not rational and not scientifically based and should not be what is recommended to patients, in my opinion.
Right, so there is an urgent need for the guidelines to be changed. Back in the day when I started using the diet for my first type 1 case, it was a 1-year-old child, and I wasn't too sure whether I should kind of. It was a low carb diet, it wasn't a ketogenic diet, and I capped it around 120 to 130 grams per day. And I wasn't sure whether I was on the right track because there were no guidelines, and and then I stumbled upon this paper of November 24. It was in the Journal of Metabolic Health, if I'm not wrong. The Society of Metabolic Health Practitioners. They actually have put down the position statement on using the ketogenic diet for type 1 diabetes now. So I was pleasantly surprised to see at least something out there that talks about the usage of this diet in even young children. Having said that, I wanted to understand from you, what is the earliest age at which we can introduce this diet to young children?
So we don't know that currently, right? So we don't have any data on if there's an age limit for when this diet should be administered. In theory, there's all this hypothetical concern around growth. Well, we just talked about growth. Is that really substantiated? It's not. And the idea behind what kids need to eat has largely been focused on, if you look at pediatric guidelines, as a certain amount of carbohydrates for brain health. Well, we know that the amount of carbohydrates needed for brain health is zero. Not saying it. The question is what's optimal, not how much is needed. And so what's optimal is a completely different question, but we know we can get and maintain completely normal glucose levels in the blood on a ketogenic diet. We also know that high and variable glucose levels completely disrupt health, even within children, rapidly in ways that are not even completely reversible if you
Right.
continue on that path, like smoking. Once you smoke for 10 years, you don't completely reverse it once you stop. So you have to intervene early and improve glycemic control as quick as possible. In theory, you should be doing anything you can to do that because it is by and large the primary risk factor for the patient of all ages. The
Right.
earlier you have the diagnosis, the earlier you're going to see signs of worsening
Yeah.
cardiovascular disease or earlier on. In fact, the younger someone is diagnosed, because of how early the dysglycemia occurs, you actually see about a doubling of life lost later
Mhm.
on in life because of the earlier diagnosis, the accumulation of
Right.
poor glycemic control associated with this. And so the earlier you can get glycemic control, the better off the patient will be. Now, the question is that harmful to have a ketogenic diet this early in life? Well, they've used it in many other patient populations like epilepsy, but a more extreme form of it,
Right.
and in diverse ages. And so is it harmful? I can't say that we have evidence that says yes or no to that, but what we can say is that there is no evidence right now that would say it was harmful. In fact, the evidence would suggest that the things that this diet can do can be incredibly helpful across all ages. And we should be doing everything we can to mitigate and manage the primary risk factors upon diagnosis because of the accumulated and not completely reversible aspect of poor glycemic control.
Right. And I second that. Actually, I've been monitoring the growth of the cases that I've been handling. Typically, these kids are less than 5 years of age, and I've not seen anything going way out of the charts. In fact, the parents always come back saying that the child has a lot of energy and has been doing well in school. We're also tracking the height and the weight and all of that. It seems to be going well as of now. So, but typically, because in India it's really difficult to kind of implement the ketogenic, the very very low carb diets to these kids, because the family's eating carbs and then you're expecting the child not to eat. So, for us it makes more sense to kind of maintain them at 100 to 120 grams per day, which is decent enough to maintain euglycemia.
It's important to acknowledge that there is no perfect carbohydrate number. So if you can eat 500 grams of carbohydrates a day and you get perfect glycemic control, power to you. But that's extremely unlikely. So whatever amount of carbohydrates you consume and still maintain glycemic control, thumbs up. That's what you want to do. That's what matters. So there's no perfect number here. It's about whatever amount of carbohydrates are allowing you to maintain glucose control. If that's zero, that's zero. If it's 150, it's 150. But each patient's going to be different based on a number of different variables.
Well, not at the cost of increasing the insulin dose for sure, because all of my cases I've seen a drastic reduction in the requirements of insulin in the total daily dose. So that's at least giving me a fair amount of, an insight that I'm on the right track with this. Okay, coming to carb counting with the low carb diet, what's been your experience? Because we do know that now, because the carbohydrates are much lower and we've pushed up the protein and fat per meal. And we do know that now we're looking at the effect of mixed meals, not just the carb aspect of that particular meal and the glucose response. Does the insulin to carb ratio get affected over a period of time? Like, does it change from what it was set at baseline once we introduce these diets, because the insulin sensitivity kind of also improves a little bit? Like, what do you see over there?
Number one, there have been analysis across all studies looking at carbohydrate counting to see how effective carbohydrate counting is as a method for glycemic control.
Right.
And in those meta-analysis, they have demonstrated that it has no improvement in glycemic control. Is it effective? Well, you have to understand the interaction between food and insulin. That's an essential fundamental to understand. It isn't just carbohydrates though.
Right.
It's also protein and how fat may interact with those foods to then change insulin requirements. So in the context of carbohydrates, we know that that's the most powerful impact on glucose in a dose-dependent manner, whereas something like protein requires around 2.5 times less insulin per gram compared to carbohydrates, whereas fat is essentially near zero. But it does have an impact, particularly in type 1 diabetes more so. And so does it change insulin carbohydrate ratio? Well, if your insulin sensitivity improves, yes, it would. But the actually bigger picture here is that the awareness now, when you remove the cloud and smoke of what carbohydrates does to glucose, these high and variable impacts on glucose and insulin's almost impossible to match and catch up with that reliably. Once you remove those clouds and that smoke, you can see clearly that actually protein has a pretty clear impact on glycemic control. And once you see that, you can now attempt to manage protein effectively. As you mentioned, mixed meals are not just pure carbohydrates. There are carbohydrates on top of protein, on top of fat, on top of fiber, on top of different compositions in mixed foods, which have different amino acid compositions, which then contribute to different amounts of glucose output from the liver, So this simplistic approach of just giving a dose per amount of carbohydrates is a pure survival technique trained to patients when they're first diagnosed. It is not a thriving technique. Okay. If you want to thrive, you need to understand these interactions and do what you can to remove the smoke, remove the clouds, see clearly on things that are actually improving or affecting glycemic control. And then you can start to manage things much more effectively. And put differently, you can get off the roller coaster and start to see more clearly what is happening in front of you. So you can anticipate and be proactive instead of what often happens in type 1 diabetes, which is being reactive.
So largely, I think I've kind of done away with the carb counting altogether for these diets, because, there's a fixed dose that we start off at. And of course, we reduce the dose slightly because we're expecting to reduce carbs. So the glucose response changes, and, the diabetologist typically starts off and cooperates and reduces the basal dose and the bolus dose. And eventually what I do is like I do a back and forth, we maintain diaries and we talk every week. And I understand that whatever I've planned in terms of the diet and, the current insulin dose, they kind of match. And then what I do is for young children, I bring in the carb counting only when they travel or when they have to eat a carbohydrate meal and there's no other option available or they're sick. Then I also teach parents how to count carbs. But largely, I think with this diet, that one, aspect it's so stressful for parents literally to keep counting because the meals are so variable. But when you get the carbohydrates down to a bare minimum and you eat more protein and fat, eventually you realize that you really don't have to sit and count the carbs. You kind of understand that it's already titrated for the day if you maintain your intake within a certain amount that the dietitian has planned for you, and you're good to go for a large part.
Great point. And actually, another way to look at type 1 diabetes is to give an analogy to another condition, which is a peanut allergy. So let's say someone gets a peanut allergy and they eat peanuts. They find out they have an allergy and they should reduce or completely eliminate all forms of peanuts in the diet. Otherwise, they're going to have an adverse response. In type 1 diabetes, you now lose the ability to endogenously and rapidly metabolize carbohydrates the same way someone else does. So in theory, you would reduce carbohydrates to as low as possible and then use exogenous insulin when you're given it to then adjust and maintain glycemic control. That is believed that people with type 1 diabetes are going to get at least one complication within their lifetime and to live 10 to 18 years shorter, even in the developed world. And it is even as short as 42 years shorter in undeveloped world. Is that acceptable? It's absolutely not. But you have to think and flip the philosophy around how you actually see this disease and how to actually manage it, not just viewing it as, oh, you have this unfortunate incident that occurred to you. And as a result, you are now stuck with having to just bolus for every single meal, eat whatever you want. This is a myth. It is something that has, I think, damaged patients. And I think we should be forthright with patients from the start. Just like if you had a peanut allergy, you can't eat peanuts anymore. But
Right.
if you're a patient with type 1 diabetes, yes, you can eat carbohydrates, but you should understand how clearly it's going to be difficult to manage them with current insulin kinetics, how slow they act compared to carbohydrates. And this is a reality we must face. It's a reality that patients and kids should be armed with upon diagnosis, and then they can make their own decisions. But we shouldn't withhold that information and that truth that is in fact the case, because then it gives them the options to choose what
Right.
they should do to optimize their health.
I agree with you completely. I think counseling is, the key thing here. We have to give them the information so that they can take an informed decision. Whether they want to still eat the carbohydrate or not, it's completely their call. But if they don't have the information, then, I don't think we're doing a good job with our practice. What about hypoglycemia, Andrew? I've seen a lot of my patients on type 1, especially in the ketogenic diet, they're able to kind of, not have any symptoms with a glucose as low as 50 and 60 sometimes. So is it similar to what happens with people without diabetes? Because we do know that the baseline glucose tend to drop on a ketogenic diet.
Number one, you still want to avoid hypoglycemia. There's actually no net benefit in having low hypoglycemic moments. So just so everyone's aware of that, if you can, and the idea behind doing a diet like this is to shrink the variability such that you can, let's say, lower the mean. So if someone's seeing this visually, imagine you have this wide range from top to bottom of these high and variable glucose levels, and then you shrink that variability. Now you can move your average down with the low end, not risking going into this hypoglycemic range as often. So you earn a better average glucose by reducing the variability. That's the philosophy people should get to, because that reduces hypoglycemia. The question you asked was more specific to how are patients able to potentially actually not see symptoms of hypoglycemia when they're on this diet and have lower blood glucose levels. Well, number one, a lot of people would hear that question and say, oh, they have asymptomatic hypoglycemia. Well, that's not necessarily the case, actually. We know that other nutrients within the diet, other metabolites that circulate at higher levels on the ketogenic diet, particularly ketones, can make up a portion of brain energy use.
Right.
We've actually studied this. So we've actually studied patients, even without type 1 diabetes, going into hypoglycemia. So Ironman competitors that went on an extremely long duration exercise, about over 2 hours in duration, some as high as 4 hours in duration, and then got hypoglycemia at the end of the exercise bout. What we found is that those athletes performed exactly the same on a high carb diet versus a low carb diet even though there's this belief that low carb diets will impair performance. And we saw, of course, that they were not. But well, I wouldn't say of course, because it actually was a little bit shocking. Now we realize, okay, of course, because if you adapted the diet long enough, what we were seeing is that while we were seeing lower average glucose levels on the lower carbohydrate diet, these individuals were not showing symptoms of that, which showed us, hey, there's something going on with the other nutrients that are providing brain energy. So what I did, we never published this, but I'd love to share with the audience, is that I actually calculated the total amount of brain energy metabolites in the circulation. Okay. And what we saw is that individuals on a low carbohydrate diet, while they had lower average glucose levels, if you accounted for ketones and lactate, which both enter the brain in a dose-dependent manner, according to how high they are in the blood, they completely normalized between the two conditions the level of brain energy needs, which means that the other nutrients circulating at higher levels on a ketogenic diet are able to supplement when glucose is not sufficient. In fact, we've known this for almost a century now, from George Cahill's work, where he illustrated that you can go on these diets, get extremely low, or much lower levels of glucose, but ketones can make up of north of 60% of the total brain energy needs. Right. So this is a very flexible condition within the brain where there's not just glucose providing energy for the brain. It's glucose, it's ketones, it's lactate, and all of these are composite and combined to provide energy to the brain. And when you switch the diet, you change the composition of those metabolites in the blood and change how much each one is contributing to brain energy needs. So when someone goes on a low carbohydrate diet, yes, we've actually seen in our own evidence that people are able to not have symptoms, even without type 1 diabetes, and still maintain normal levels of brain function. So not to say that they should encourage hypoglycemia. No, you should not. You can avoid it at all costs. But this idea that some people don't see symptoms is actually totally mechanistically plausible based on how we understand the brain works around other metabolites.
The only difference would be that in people who don't have diabetes, they don't consume exogenous insulin. So we do know that insulin has a negative feedback, effect on the production of ketones. So coming back to that, what kind of level of, when you introduce a ketogenic diet, and we talk about nutritional ketosis, not DKA, what kind of, level of ketones would you see in the blood?
So it depends whether you're talking about type 1 or not. So if you're not looking at type 1, if you're someone who is typically measuring ketones, they're probably doing it first thing in the morning. And if you go on a ketogenic diet, what would you expect? Well, most people who are not on a ketogenic diet, when they first wake up in the morning and they get what they call is this fasting plasma glucose level or a ketone level in that morning, what we see is that those levels are typically on a high carb diet, even though that's after an overnight fast, around 0.2 at most, 0.0, 0.1, or 0.2. If someone's on the ketogenic diet, then we start to see that level increase around 0.3 or higher. And the same is true within type 1 diabetes, where we do see some studies where individuals can be as high as 0.3 in the morning, but the reality is that they're almost never reaching that level until they get to lower carbohydrate consumption and higher ketone production as a result. So we would expect that 0.3 is really that threshold where we start to notice a measurable difference with a diet-induced change.
Right. And the difference between that and DKA would obviously be the blood sugar readings, right?
It's actually a very complex mix of measurements. So this is a huge misunderstanding that if you have elevations in ketone bodies on a ketogenic diet, that means you're at elevated risk for diabetic ketoacidosis. Right. So because of the lack of guidelines and the lack of understanding on how to implement this approach, we actually wrote our own international institutionally backed from endocrinologists, dietitians, people living with diabetes, myself, all in contributing to this with over 10 reviewers internationally who often live with type 1 diabetes and are healthcare professionals or scientists in the field. And we specifically put a table in there to distinguish what's the difference between nutritional ketosis, diabetic ketoacidosis, and someone who has diabetes who's on nutritional ketosis. You said it correctly. The key distinguishable difference is that there's often a high glucose level on top of a high ketone level. in the context of diabetic ketoacidosis, which distinguishes it. But it doesn't always account for it because there are cases of euglycemic diabetic ketoacidosis. They are extremely rare, extremely rare, but they do exist. And so there are some scenarios where glucose levels can be normalized and you can get into DK. But those are scenarios usually where someone has illness, pregnancy, caloric restriction, some composite therein, where someone is actually seeing these elevations, not because of the diet, but because of these underlying increase in metabolic rate due to other factors that may contribute to an acceleration of ketone production at levels that may be problematic. But truthfully, it comes down to really symptoms. But we typically see that somewhere between a 0.3 to 0.5 or 5.0 millimolar range is completely aligned with normal physiologic levels and on a ketogenic diet. And those ranges are completely aligned with normal healthy levels. Now, if you have type 1 diabetes not on a ketogenic diet, physicians start to get concerned when you go to 0.3 or higher. And it's actually diagnostic to when you're at 3 or 4 millimolars to actually diagnose DKA. Low carbohydrate ketogenic diet and type 1 diabetes, that's a completely different clinical scenario. And physicians should be informed of this because we actually see record levels of patients doing these interventions today.
Right. Is this resource available, the one that you just mentioned? Is it open for everybody?
It's free and publicly available to everyone internationally. So it's actually now in multiple languages. It's in French, it's in English, it's just getting translated to Italian. And there are other individuals who saw the guidelines because this was completely, basically motivated by people within the type 1 diabetes community realizing this resource was not available from institutional bodies, despite it being alerted to institutional bodies, this lack of resources. And so we had to do it ourselves. It essentially was for the people, by the people, for the people. So it was made by people with type 1 diabetes, for people with type 1 diabetes, or for individuals treating individuals who are living with type 1 diabetes. Because we knew that this was such a powerful resource. We knew patients were doing this at record levels. And we also knew that there was a separation in relationship between the healthcare practitioner and the patient and caregiver that was evidenced and cited, showing that this inability to help patients on their journey causes patients to often go with minimal or no healthcare support on this dietary intervention, which has powerful impacts on insulin, powerful impacts on glucose control, and interacts with other medications, often in a very good way. But having no healthcare guidance has failed both the patient, the caregiver, and the healthcare practitioner, both of them, and has caused the relationship between them to be fragmented, which is a total failure. And so we attempted to address this. It's totally publicly available on the Institute for Personalized Therapeutic Nutrition's website. Search type 1 diabetes, Institute for Personalized Therapeutic Nutrition guidelines. And what you will find is a resource for individuals in the healthcare community trying to guide their patients on a healthy approach with this diet, so they're not lacking the resources necessary to have that healthy relationship between the practitioner and the patient.
Fab, I'm going to get my hands on that one. Talking about fat when consumed alone, how does it affect type 1 diabetics? So fat is known not to cause that kind of a glucose response. So is there any hypoglycemia or delayed hypoglycemia that we see like with protein, also with fat in these cases?
So that first your question around fat. So does fat affect insulin differently? It does in type 1 diabetes. We see that if you just consume fat from food sources alone in non-type 1 diabetes scenarios, we don't see any measured difference in insulin across most studies. There are some dietary scenarios where you have higher fat intake that then leads to metabolic changes. If it's like a Western diet or an obesogenic diet where you couple high carb with high fat, well, yeah, you might see some metabolic issues related to that. But in type 1 diabetes, because, well, number one, there is data to show that fat causes a dose-dependent elevation, albeit much lower than carbs and protein, in insulin needs. And we don't entirely know why this is, but all plausible evidence that we understand from biology and physiology suggests that because of the route of administration through exogenous insulin, and by the way, this is not out there, this is just my thoughts on this issue, because it's in the peripheral vasculature, it's touching peripheral tissues like muscle and fat disproportionately at higher levels, which could be a benefit to athlete if you know what you're doing, by the way. But nonetheless, because it's touching those tissues, those are the tissues that at very high levels of fat are typically more insulin resistant. the liver, not so much. And so as a result, if you're almost all of the insulin you're injecting is going to those tissues that are more sensitive to fat in type 1 diabetes, if you get extremely high levels of fat in some scenarios, you're more likely, I assume, to see elevations in insulin requirements, which is not necessarily pathological, by the way. This is just normal physiology. People get all wound up around fat increasing insulin levels. And no, like this is completely normal physiology. This is how it works. This is part of the process. And shouldn't be a point of concern by any means. In fact, when most people go on a higher fat diet with low carbohydrates, they lower the total insulin load. And
Right.
so just make sure people are aware of that key distinction and nuance.
I mean, another pathway would be the glycerol, pathway where there's gluconeogenesis from fat as well at some point, right? So,
Yes, but it only contributes at most 5 to 10% of total glucose from
right,
a ketogenic diet. So
right,
it's even in those scenarios, it is, yes, you're correct, but its contribution is extremely low.
right. Okay. Talking about, changing the insulin regimen when you get on to these diets, what is it that you typically see or do for people when they get on the low carb or ketogenic diet?
Insulin levels often go down, primarily bolus-based insulin. Basal insulin usually changes in accordance to insulin sensitivity or total body weight. And so the ratio typically is recommended to be 50 bolus, 50 basal. Well,
Right,
bolus goes down and you typically see something like an 80-20 ratio now, where you're 20% bolus and 80% basal. But on average, when someone goes from a standard moderate to high carbohydrate diet in type 1 diabetes all the way down to a very low carbohydrate ketogenic diet, we see that the insulin requirements often go down around 50% on the average. So it's an important distinction for people to understand.
but can we kind of modify the way the bolus doses are given, like a split bolus or, moving on from a standard bolus? Because we do know that when we push in protein and fat into the meal, then there is delayed hypoglycemia. So how do we kind of tackle that delayed response or, glucose that comes in 3 to 5 hours later?
This is a strategy that requires understanding the kinetics of each food, each macronutrient. So carbs are very quick and rapid. They get in and out of your system mostly
Right,
they peak at 30 minutes and they're mostly out of your system by 60 minutes. Fat typically doesn't peak till an hour to 2.5 hours, depending on the type of fat. And if you mix it with, protein. Protein typically peaks at an hour to 2.5 hours. And if you mix it with fat, it may, blunt the peak and extend it. When we talk about the different impacts of macronutrients, it's important to appreciate that carbohydrates have a rapid elevation in glucose, typically peaking in its insulin requirements within 30 minutes. And we know that exogenous insulins usually peak at 90 to 120 minutes. So this is almost never going to match. But in the context of protein typically peaks at an hour to 2.5 hours post ingestion.
right,
It's much more delayed and it typically stays elevated for 4 to 6 hours. If you add it with fat, they may extend it even a little bit further. So you have much less of a spike, but it's much longer. And so what insulin would you give in this scenario? Well, pumps often allow for you to delay the bolus. You have an initial bolus and then, often patients will use 50% up front and 50% delayed over the next 2 to 3, maybe 4 hours, depending on the meal. And so you can extend the insulin, so much lower insulin, but it's much more extended. This is the philosophy in type 1 diabetes people should understand to thrive and optimize, is to have tight relationships between the glucose impact of food with the insulin kinetics. If you're not using a pump, one common strategy is use something called regular insulin, so Novolin R or Humulin R. These also match that kinetic profile of protein
right.
and fat. So it's a different insulin strategy that you must do. You can't just lower carbohydrates. Yes, that oftentimes helps, but it's not sufficient. You often need to also incorporate the right type of insulin strategy to now match these different impacts of food that's much more delayed. So if someone just took rapid acting insulin with protein and fat, they may cover the first 2 hours, but then at the 2.5, 3 hour mark, they may wonder, why is my glucose elevating with their hands up in the air? And we have always known that if you understand how protein is now interacting with food and these other subtle differences, you can easily predict and manage these common question marks that arise with the diet. And so it's about providing resources and understanding how to manage this.
Right. And regular insulin is one of the options in these cases.
Yes, and typically most people are unaware of it. There's even an option at all. It's obviously not something you'd use with carbohydrates, but it's something that has often used for something like protein and fat.
All right. So thank you so much for joining me today. And all your insights, all the inputs that you gave were extremely valuable. I look forward to having more such sessions with you and discussing, other conditions where the diet can be used, for example, sports or, pregnancy for that matter.
Thank you so much for having me. And if anyone wants more resources, obviously you can and check out the Instagram channel that you saw this on, but also there's resources at andrewkoutnik.com for those who want more.
Will do.
Thanks for tuning in. We've just scratched the surface, but I hope this gave you clarity on how very low carbohydrate diets can be a tool, not a threat, in managing type 1 diabetes. Whether you're a practitioner or someone managing diabetes daily, there's no one-size-fits-all approach. But questioning the norm and leaning into real data, that's where better outcomes begin. If this episode made you think differently, share it with a colleague or friend who needs to hear it. You can find more science-backed content on my Instagram @Shwetha_Bhatia or visit shwethabhatia.com to connect. Till next time, stay curious, stay informed.